I think I will proceed then, and in a similar way that Ashley has done, I will give you an overview of the treatment landscape today, and very briefly mention the different therapeutic options, and we will then dig into details in the forthcoming presentations. This is how it looks like in Uppsala just now. We have 60 centimeters of snow, so it's nice to come to this symposium. If you look at the hallmarks of GEP-NETs, as Dr. Grossman already have pointed out, these patients often present with diffuse symptoms, and in my experience, there is always a doctor's and patient delay. And unfortunately, that has not been reduced. I have been working for more than 30 years in this field, and it's still 3 to 4 years delay in most patients coming for a correct diagnosis. And as you well heard about before, more than 60% present metastatic disease. And also that we have a very variable growth rate. And they express a lot of specific receptors, which will be a target for both diagnosis and treatment. And most of them, and many of them, are highly vascular. So when we look at factors, at least as I see them, influencing the therapeutic decision, of course we want to know the type of NET. We are mainly going to discuss today GI tract NETs and bronchial NETs, but there is a lot of other neuroendocrine tumors that will not be covered during these sessions. We will also note the TNM stage and grade, as you have heard before, and extent of liver involvement. If you remember the presentations on the PROMID study, that patients with lower liver involvement had a significant better outcome compared to those with higher liver involvement. Functioning versus non-functioning tumors. And of course, patients' performance status and availability of different therapeutic modalities. And I must say that all our patients are discussed in a tumor board, so many of them receive a combination of treatment modalities, and also, of course, dependent on the availability. Today, these are the therapeutic options as I see them. Surgery, which is going to be discussed in deep by Dr. Falcone, and as we heard, 60% were spread disease, so curative treatment is rarely obtained in many of these patients. We can do a lot of debulking procedures, radiofrequency ablations, embolizations, chemoembolization, and most recently also radioembolizations. Irradiation, external irradiation, is mainly for bone and brain metastases, and then we have the tumor-targeted treatment, which will be covered by other speakers later on. And then we have the medical treatment, cytotoxic treatment, the old standard, biological targeted treatment, a lot of different agents. Sometimes I say that we have more agents than patients. Radiofrequency ablation is well known to most of you, and it's a very convenient method of reducing the tumor bulk, and that will be discussed in detail later on. Radioembolization using different microspheres, spheres or other spheres, and they can deliver high doses of radioactivity locally to the tumors. The good thing with this is that it's given locally. You don't necessarily need to have somatostatin receptors to get this treatment. And you have these different spheres. I think in US they're more like the teraspheres, whereas in Europe and Australia we like the spheres. And here are some data from the largest study so far using radioembolization by Kennedy in US. And you can see that there's a high number of CR and PRs. So it's a quite effective way of reducing the tumor bulk in metastatic disease. However, you must realize this is a rather cumbersome method, taking several days to perform with all the pre-investigations, and it's also very expensive. Peptide-Receptor radionuclide treatment is a type of treatment increasing in importance over many countries now. It started in Europe, and particularly the group of Eric Krenning in Rotterdam, and then we have some others, Paganelli in Italy, and the Basel group. And we have also done it now in patients in Uppsala. And we have different radioactive ligands. We started to use indium, but very weak activity. And nowadays, yttrium-90 or lutetium-177 are the main players. There is still some role of MIBG, but in a rather limited number of cases, particularly classical carcinoid tumors. This is our own experience from 230 patients now, about 43% responses and stable disease in 54%. If you look at the Rotterdam experience, it's quite similar, and it's not surprising because we are using the same protocol. The difference is that we are using dosimetry to try to individualize the dose for each patient. And the median time to progression from this paper from Kvekebom, published a couple of years back now, is indicating a very long time to progression, and also overall survival, and median overall survival from diagnosis. So that will be discussed by Dr. Gross in details in the next presentations. Cytotoxic treatment. When I started to work in this field, we had a combination that was quite used of streptozotocin, 5-FU, or doxorubicin, and that was actually introduced by Chuck Mertel at the Mayo Clinic. And that was back in 1977-78. And it showed some dramatic responses, particularly in pancreatic NETs. And however, the old data we have is not quite reliable because they didn't have CT scan or other sophisticated radiology at that time. Usually they palpated the liver edge and based the response on that. So if we look at the modern studies and look at pancreatic NETs, Kowaraki have shown objective response in 39% with a median survival of 40 months with a combination of dox and streptozotocin and 5-FU. However, if you look at the carcinoids, the classical mid-gut carcinoid tumors, the objective response rate is significantly lower, and also the median survival. And actually, my feeling was that in some patients, we even shortened the survival in some patients with classical mid-gut carcinoids by using cytotoxic agents. So it's clearly not first-line treatment for low proliferating NETs. Temozolomide has come more and more into clinical use. It was originally registered for gliomas, and we treated back in 2002 the first patient with brain metastases with temozolomide with an excellent response. So therefore, we decided to see if it could have some effect in NETs. And we were using it mainly as third-line treatment. And these are some early studies from our group showing the overall response rate of 14%, which was not that impressive. But if you look at those with low MGMT, this DNA repairing enzyme, this effect was significantly higher. And then we have some combination treatments, by Isakov and Kulke using capecitabine or bevacizumab. And looking at the response by MGMT expression, you see a clear difference. So there, for the first time, we might have a marker of possible response to a specific cytotoxic treatment by analyzing the expression of MGMT. And this is all the same type of, but when we look at the MGMT expression by immunohistochemistry, it's a difference between pancreatic NETs and typical clinical carcinoid tumors, where almost the majority of the carcinoid tumors present high MGMT levels, whereas the pancreatic, half of them have very low levels. So that is something we had to look more carefully into in the future and see if MGMT is a good marker for response. And this is the most recent trial, a retrospective review of 33 cases treated by a combination of temozolomide and capecitabine. And as you can see, the PRs, 70% by RECIST, is really high. So I think this has to be confirmed, of course, in a randomized fashion in the future. Now moving into molecular targets. And as I said, we have more drugs there than we have patients soon. And this was a nice slide I got from Marianne Pavel, and actually indicating all the different possible agents that can be, the receptors that can be targeted. And I will start with looking at inhibitors of angiogenesis, other molecular targeted treatments, and of course also somatostatin receptors. And we have a new somatostatin analog, SOM230, which will not be discussed in detail by me. But we must realize that we should not throw out the old somatostatin analogs. And I got the first somatostatin analogs in 1984, and that was, of course, Sandostatin or Octreotide. And today we have two available active analogs. And it's quite well known that we had a good effect both on diarrhea and flushing. But most recently, we have also got confirmation on data that we had expected from the previous days, that you have an anti-proliferative effect of somatostatin analogs. And this is the PROMID study, giving Octreotide LAR 30 milligram compared to placebo. And I just show you this slide, and it's showing the difference in progression, in time to progression, comparing the LAR and the placebo. So it's obvious now that we have an anti-proliferative effect by somatostatin analogs. And if you look at the most favorable treatment outcome, those with lower hepatic tumor load had a significantly better response. So again, coming back to my first slide, that tumor load in the liver might be of interest to put into your treatment algorithm in the future. Resected primary, these were mid-gut carcinoid tumors treated with somatostatin analog. And that is something that we observed also in a retrospective study, that if you resect the primary tumor, you have a significantly better outcome. And there was no difference between functioning and non-functioning tumors, which resulted in a change in the guidelines in different countries. And I think US was the first actually to change the guidelines. So the NCCN, rather early on, before the real publication, change the guidelines and allowed non-functioning tumors to be treated with somatostatin analogues, particularly Octreotide. NETs and angiogenesis. I pointed out in the beginning that many of these tumors are very vascularized. And we have a lot of inhibitors, and that will be covered by Dr. Scarpa in his presentations, and I will not go through, but as you see, if you use them as single agents, they give overall responses in 0 up to 18%. So in my perspective, these drugs should be used in combinations. In the end, I would like to comment just briefly on the RADIANT studies and the Everolimus and combination with Octreotide LAR. You will hear that in detail by Dr. Yao. But the mTOR pathway is a very important signal transduction pathways in neuroendocrine tumors. And we see mutation of the P10 and tuberous sclerosis gene in many of these patients. And it's also interesting that you have a crosstalk between the mTOR pathway and G-protein coupled receptors. So therefore, you can foresee that you can get a synergistic or additive effect of combining agents that signal through the G-protein coupled receptor as well as the mTOR pathway. The RADIANT-1 trial was the first trial that James Yao did, and he had 2 cohorts of patients, one receiving just Everolimus, and the other one receiving a combination of Everolimus and Octreotide LAR. I must point out that this is not a randomized trial. It's 2 cohorts of patients. And if you look at the clinical benefit, it was higher for the combination, and that will form the basis for the forthcoming studies called RADIANT-2 and RADIANT-3. If you look at PFS, it was significantly better than for the combination than for the single treatment with Everolimus. And this is a RADIANT-3 trial. I will not give you any results, just showing that the Everolimus TM 10 milligram was compared to placebo plus best supportive care. And then we have the RADIANT-2 study. The RADIANT-3 study was done in pancreatic NETs, whereas the RADIANT-2 study was done in carcinoid tumors, not only midgut carcinoid tumors, but also other locations, bronchial tumors, and some other odd locations. And that will also be discussed in detail by Dr. Yao. I want to say some words about Sunitinib, because now we have 2 agents for pancreatic NETs. And I will come back tomorrow to discuss with you how should we use these 2 drugs for pancreatic NETs, because it's the first time we got drugs that are confirmed to have an anti-proliferative effect, anti-tumor effect in randomized phase 3 trials. So we had to discuss where should we put them into the algorithm. And these are the data from the Sunitinib study, where Sunitinib 37.5 milligram were compared to placebo. And if you look at PFS, the 11.4 months versus 5.5 months for the placebo arm. So if you look, then you will see the data from James on Everolimus. It's a blueprint of the same overall, the same median PFS. So coming back to what Dr. Grossman and also Humphrey Bogart pointed out, you need to work in a multidisciplinary team. And we have heard all this. Furthermore, not only seeing each other and saying hello and discussing patients, you should have a formalized tumor board that meets regularly to discuss the patients. And working in such a way, you saw already some data from Dr. Grossman. I just want to show you what is the results of working in a multidisciplinary team, as we have done for more than 10 years now in Uppsala. And I just take the data for metastatic midgut carcinoid tumors and comparing the survival data that can be obtained from the SEER database. I want to point out that the American SEER database, these are the standard of care that patients going to any doctor, any oncologist in US can obtain. It's not the results from specialized centers such as MD Anderson, Tampa, or so forth. So you can see the difference in survival, and not much has happened during the last decade in terms of median survival in the general population of midgut carcinoid tumors. So by that, I stop, and thank you for your attention.